Now I'm going to Sylvester Kimaiyo, I don't know if I pronounce it well, Sylvester, to talk about AMPATH, another model, which it's a collaborative partnership from between Moi Teaching and Referral Hospital in Kenya, Moi University College of Health Science, and a North American consortium led by Indiana University. It started with HIV, but is now becoming more integrated and targeting other NCDs and other conditions. Sylvester has an MD and it's a professor at Moi University. So welcome, Sylvester. The floor is yours.
Good morning. Yeah, I will just continue from where Miriam started. And actually, we started with Miriam, or the first PEFA, and the early childhood education for AMPATH'S started with Columbia University. And I also want to say that having joined with the Harvard School in the Open MRS platform, so this world is just intertwined. This is a journey of 30 years for Moi University and 20 years for AMPATH. So I will just highlight, 20 years in 12 minutes is not very easy. But these are our partners. USAID forms our backbone. We get PEFA funds through USAID, and without the backbone, everything else doesn't work. And so we have everybody else there supporting one part or the other in our program. And what I don't have here is the research side led by NIH. And so what is AMPATH? It's an acronym, Academic Model Providing Access to Healthcare. And why did we form AMPATH? We formed AMPATH to look for funds, extramural funds, outside the university, outside the hospital, and outside the Ministry of Health to support care, research, and training. Perhaps the only difference we have with some other consortia is the fact that care leads the way. And care, on one side, research and training are not divided by an iron curtain. It is one. That is the only difference really AMPATH has, but this is all replicated in most other consortia universities. So we first published the description of AMPATH as a WHO publication in 2003, and we got better in 2007 and gave a better description in academic medicine and gave the details of the tripartite mission. And just to show right here, we think we achieved what we were looking for in terms of bringing our funders to the table or our supporters to the table. Right there is all the USAID chiefs of parties in Kenya came for benchmarking at AMPATH on how we do things. And this is the top level USAID team led by the mission director in Kenya visiting AMPATH in one of the one of our sites to see how we do things. And this person here is Roger Glass, visiting AMPATH to look at the research side of it and the funding from NIH. And on the other side is Redfield from CDC, discussing how we can do things together. So we started with just 2 clinics, one in Eldoret, one outside Eldoret in a health center. And by 2019, we are supporting 800 clinics in 10 of 47 counties in Kenya. And so this is a catchment population of about 15 million people. Our patient volume now is 150,000 patients on treatment. And here is the small journey, 1988, foundation of Moi University. admits its first students in 1990. The rest of 2 years was preparatory. And 1997, Moi Teaching and Referral Hospital was hived from a district hospital. And 2001, AMPATH, tackling HIV. And 2008, we actually expanded into chronic disease. I was running a cardiology clinic as well as a HIV clinic then. And just at the right time, NHLBI put up a grant for cardiovascular and pulmonary centers of excellence. I mean, that's where I met Pao as we worked together in this field. And then 2016, we are doing what we should be doing, population health. And this is everything together. And I just want to show here that 2010, we signed an MOU with the Ministry of Health in Kenya to do NCDs. And just immediately we got into this. We got from Miriam, from when we started, we had issues with space, staff, testing, etc., etc. We actually realized those are the WHO building blocks of in health. And so we had to tackle each of these every step as we moved on with our program, as we treated HIV patients. Just seeing some of the spaces we managed to have and build. Of course, when I say these in the skyscrapers in New York, but these are real for our patients in Kenya. From tents and others to this is a fantastic thing. And the latest addition is our Chandaria Cancer and Chronic Disease Center. We were holding them in the tent in the HIV clinic or in a corner of the HIV clinic, but they have their own building now, so they are disintegrated to super specialty. So what really makes us successful? I've already shown the academic partnerships and the electronic data repository of every visit, whether it's oncology or HIV, in the OpenMRS platform. And also the institutional and GOK support. We have our own funding. We are a parastatal of the government of Kenya. But once we get the money, we behave like an NGO. And we have one central nervous system, and we have patient numbers to be able to make every statement from the data system. So then, the academic partnerships is Moi University, Moi Teaching and Referral Hospital, and what has already been said. What has not been said is we work with the government, 10 county governments. It's like a marriage. We get into the marriage, and we face everything together. Your problems are our problems, and so we deal with it. I think that's the interesting part. We also work with the national government. And these are our partners, very many of them from North America. I just spread them like that to make it easy. And we work with government. So I just want to show some of this is the First Lady of the Republic of Kenya and the various governors, and others shown that we have to work with them and meet with them. And what really gives us the key is our medical education, is innovative medical education, like in the Walter Sisulu or others, that is innovative. It's not lecture method. It's small group discussions, etc. And where we have our clinics is where our students were going to. And patient numbers, just to show, from one patient to ever enrolled, 200,000, 150 active. Look, our research dollars also follows the same curve, just like our publications. So it's the right way to go. It just follows each other. Well, of course, the publications don't just come. You have to work for them. And so when I put them together, they are the same curve. One is patient and so on. So leading with care is a clever thing. But then comes integration. We have to integrate, piggyback on the HIV program. And occasionally a few problems. We did that once in one clinic, and the HIV indicators got messed up. So we sat back again to relook what really happened. The others came without anything. They came to ride on our systems. So I have 4 projects going on now. The first one is funded by World Bank, integrating hypertension, integrating 4 diseases. We call it PIC4 disease, hypertension, diabetes, cancer breast, cancer cervix. And in one area, so I have a big experiment. I am doing hypertension and diabetes screening together and get the patients in. And in the third one is the ideal one that we'd like to do. We call it population health, universal health care, comprehensive community and facility first, and we take care of hypertension, diabetes in the HIV clinic. And we do IGS, we do National Health Insurance Fund. I'll finish on time. And then I have one that is very interesting. I wanted to do a bigger integration like the population health. But wait a minute. You have the entry point is hypertension, and then HIV, and then the others follow. Of course, I have a challenge. I know what I want to do, a very good integrated system, but I have funding for hypertension and HIV. I'll see what to do in all this. So, this is the disintegrated one on the left, and this is where we want to go, right here. But it has a few challenges. You know, should we integrate everything? I think no. I think we integrate at the level 6, level 3 down. Sorry, we have specialized, disintegrated, but good communication in level 6, but in the all level 3 coming down, what we probably need is an integrated system. I think that's the solution. My 4 big experiments across the 15 million population will tell us the answer. I know what we want to do. Thank you very much. Just on time.
Thank you, Sylvester, for such an impressive presentation. I'm sure you have a lot of questions, so save them. But basically, a couple of lessons learned. Partnership, loose partnership, all together putting their value added together for the benefit of the people. And also showing it is possible if we put the efforts, the funding, and finally, it will be successful if the government bites in, and he shows that. Because so many experiences has failed in the past. Many institutions come into countries and then it's not sustainable after they publish their results. But this shows that if you get the government on board, then it can work and it can be expanded.